Hello again, everyone. Today I'll just be pretty much doing the introductions for those who will be presenting from North Carolina Integrated Care for Kids. We're going to start with Ms. Sarah Allen, MPP. She's the Managing Director for North Carolina Integrated Care for Kids. Sarah's passion for promoting child and family well-being grounds her research interest in strengthening public sector services for children, especially those insured by Medicaid and CHIP, and those engaged with the child welfare system. She is also a policy fellow for child and family health policy at the Duke Mariglaw Center for Health Policy. Prior to Duke, Sarah served as an assistant director of the Harvard Kennedy School's Government Performance Lab, where she managed teams providing assistance to state child welfare and Medicaid agencies. Sarah holds a master's in public policy degree from Harvard University, Jeff F. Kennedy School of Government, where she is a Glenn Smith Fellow for Social Change and the editor-in-chief of the Kennedy School Review. Next, we have Richard J. Chong, MD. He's the Population Health Co-Director for North Carolina Integrated Care for Kids. He is also a professor of pediatrics at the Duke University School of Medicine and an adolescent and young adult health specialist at Duke Health. His academic and research interests is focused on chronic conditions in adolescents, behavioral health, and neurodiversity, positive youth development, and population health management. Next, we have Judy Lawrence. Has served as an integration and consultant with the North Carolina Integrated Care for Kids based in the North Carolina Division of Juvenile Justice and Delinquencies Prevention since November 2021. This role focuses on integrating the support and resources provided to DJJDP involved youth and their families across multiple core youth services areas. Ms. Lawrence has worked with the state of North Carolina since February 2007, holding leadership roles with North Carolina DHS, the Administrative Office of the Courts, and DJJDP. She has led migrant projects from TNF and SNAP programs, administered a district garden and admitment program, and managed the National Work Support Strategies and SNAP collaborative initiatives. Ms. Lauren earned her Bachelor of Science degree in Family Studies and Human Services from Ohio University in 1998 and achieved her Lean Process Improvement certification for North Carolina State University in 2015. Next, we have Elise McAllen. She's the Senior Program Coordinator for the North Carolina Integrated Care for Kids. She has a bachelor's degree in criminal justice and political science from East Carolina University. After graduating from ECU, she returned to Durham, where she served as the A.J. Fletcher Community Engagement Fellow with Duke's Office of Durham Affairs and American Crops Vista Organization's Youth Advisory Council, developed training materials for educators, and helped launch an equity mapping process for Durham public schools. Elisa is currently a Master of Social Work candidate in the class of 2023 at the University of North Carolina, Chapel Hill. Ashlyn Wolard, LCSW, is an integration consultant with North Carolina Integrated for Kids based in American Health, Cardis of North Carolina. She received her Master's of Social Work in 2012 from North Carolina State University. Ashley is a licensed clinical social worker with experience providing clinical case management to children and families with complex needs. She also has experience working with children in therapeutic foster care, helping families navigate the juvenile justice system, and providing individual, group, and family therapy. Now that we have the introductions of all the speakers, we can move on with the actual presentation. We are excited to hear from you all today.
Excellent. Thank you so much for that kind and generous introduction. My name is Richard Chung. I'll be the first of a few speakers from the North Carolina Integrated Care for Kids team. Just wanted to first thank the organizers of the conference for the invitation. It truly is an honor and privilege to be with you, albeit virtually. And we come really with a posture of wanting to share out the work that we're doing as it relates to young people, but also to really learn from you all, from the other speakers, as well as the attendees, and particularly for the youth panelists, to really understand how we can continue to really push forward the work we're doing on behalf of youth. North Carolina Integrated Care for Kids is funded by the Centers for Medicare and Medicaid Services, so through the federal government, which is a part of the U.S. Department of Health and Human Services. And amongst the children and youth that are served in the model, certainly youth in transition are a key part of that broader focus, in particular mental and behavioral health, which I understand is a keen focus of today's conversation. While NC Inc. as a whole is in itself not a specific policy per se, it is a manifestation of people in a capacity to make decisions, to apportion resources in a particular way, deciding to do so. And to the extent that policy is largely that, decision makers taking information and making a decision about how to apportion resources and supports, I think Inc. is highly relevant to this. One thing we'll also kind of share out is that when we're developing a model like Inc., within that model, there are a slew of sort of focused policies that emerge just through partnership and working with young people and families. And so we do have one specific policy example that Judy will share about later that's relevant to young people who are engaged with the justice system. And so with that said, we'll move forward kind of to the next slide. I wanted to just briefly mention social drivers of health, which I know is likely familiar to many or probably all of us at some level. These are social and economic factors that influence health outcomes for really all of us, but I would say particularly for children and youth who are growing up through different environments. And what we know is that these social drivers typically have an outsized impact on health outcomes, in most cases larger than what I do each day, which is healthcare service provision. All of it's important, but I think recognizing the sort of key factors like social drivers is critical. And this is an important foundation for the work in NC Inc., really moving beyond the walls of a clinical care system to really engage the broader sectors and provide a more holistic approach to support. Next slide. What are the goals of the Inc. model? So first, to improve performance on priority measures of child and adolescent health. And certainly in the Q&A and conversation, we would love to really delve into what this means, because like with any good work, if you can't evaluate it sufficiently and prove the point of the value of what you've done, you've only done so much. And so that is definitely a key part of our ongoing work. A second piece that's actually a keen focus of CMS, which is again the federal agency funding this work, is to avoid inpatient stays as well as out-of-home placement. So that can include sort of traditional healthcare hospitalizations for mental, behavioral, or other health needs, but also out-of-home placements in the form of foster care placement as well as justice involvement. And then the third piece, which we won't talk about quite as much today, is to create sustainable alternative payment models. These are creative means of taking what often are limited resources, in our case, the Medicaid system, and apportioning them in a way that maximizes impact for children, youth, and families. Next slide. I mentioned that this is a sort of funded through CMS, and so there are actually 8 Inc. sites across the country in 7 different states. In North Carolina, Duke University is the primary awardee in partnership with the University of North Carolina at Chapel Hill, as well as our state Health and Human Services and our Medicaid office. Next slide. All right, so what is Inc. more generally? So essentially, it is a demonstration model centered on care management services for children and youth. So care management, as may be familiar to many or most of you, is sort of a collaborative approach to supporting young people and families in between healthcare appointments or hospitalizations, right? It's the in-between that really matters the most in supporting young people in navigating systems and structures, particularly during this time of transition. And so NC Inc. is really trying to develop a model that optimizes engagement and outcomes in this care management infrastructure. It is for young people with Medicaid or CHIP, the Children's Health Insurance Program, insurance in these 5 central North Carolina counties: Alamance, Orange, Durham, Granville, and Vance. And it is from birth through age 20. So our model includes younger children as well, but also those first critical years of that transitional period into young adulthood. NC Inc. works closely with medical homes or primary care services. We recognize that primary care venues are really kind of a key foothold for really making an impact in the lives of young people. And our services launched last year. That was the first year of our implementation, and we have actually a fairly generous runway of 5 years of implementation through the year 2026. Next slide. So there's a lot under the hood of the model. To kind of simplify things, there are 3 main threads of work that we like to kind of braid as we talk about the model itself. So the first is to understand the needs of young people. Certainly, if you can't understand the needs and opportunities in the life of a young person, then you can't really meet them where they are and support them appropriately. The sort of key wrinkle here from an Inc. standpoint is to do so a bit more holistically than what traditionally we've done in the past. Healthcare systems typically use healthcare diagnoses and healthcare utilization, so very medical healthcare centered data to really stratify young people and understand their needs and opportunities. The Inc. model is taking in data from other sources, including the educational system, child welfare, as well as the justice system, to provide a bit more of a holistic view of each young person and how we might best support them. The second thread in the purple is to integrate services across sectors. So support and bridge services, inclusive of healthcare, but going well beyond. I think one of the challenges I see all the time as a healthcare provider is that we're quite siloed in our impact. Even in sort of the key relationship between clinics and schools, which are two major domains of the life of a young person, there's often very little interplay and communication. And so we're trying to work to really create more linkages. And so we'll talk a bit more about that. And then the third piece, very briefly, in the light blue, is the focused healthcare investments. This idea of alternative payment models, again, redirecting resources in a way that can more directly impact young people and their health outcomes. Next slide. So this is just a brief view of our journey. So in 2019, the grant was awarded. North Carolina, again, was one of 7 states awarded funding. There was this really valuable 2-year planning process, which we'll talk a little bit about in terms of engaging families and young people along the way. This was a coalition of cross-sector partners working to build a model. And then the next phase is where we are currently. So implementing the model across a 5-year implementation and evaluation period. The 3 pieces here in red, purple, and blue are sort of what I just mentioned, using data across different sectors, schools, healthcare, child welfare, and juvenile justice to understand more holistically what's going on with young people. The purple is alluding to a partnership with our Medicaid agency, as well as different entities that administer Medicaid in our state, to elevate and really strengthen care management for a particular portion of young people in our catchment area. In the Inc. model, there's close to 100,000 children and youth. Among them, 15,000 through our sort of data approach have been identified as really benefiting potentially from more intensive supports in care management. And so that's what that purple is. And then the light blue, again, is the new payment model. The idea here is to take sort of these 5 counties and the 100,000 young people in them and to really figure out what might work best to support young people to thrive and their families as well. And then the idea after that is, after the sort of implementation, to the extent that we have positive impact and can demonstrate that through concrete data, to really scale this to other counties across the state, to really create new knowledge and understanding as to what actually works for young people. And so that was a far too quick kind of overview of the Inc. model. But what we're going to go into next is we'll talk a little bit about family and youth engagement, which is a keen focus of today's conversation in this conference as a whole. We'll talk a little bit about care management for young people and what that's looked like so far and what we need to continue to improve and learn. And then we'll talk a little bit about justice-involved youth as a specific policy focus. But at this point, I'll turn it over to Alicia.
Thanks, Richard, and thanks everyone for being here. I'm Alicia McAlman, the Senior Program Coordinator for Inc. And so I want to share a little bit of insight about our specific practice and engagement with families and how we gather perspective. Next slide, Josie. Thanks. So in the early planning phase of NC Inc., there was an understanding that there could be a lot of value that came directly from parents and caregivers who are caring for children who would ordinarily qualify for the Inc. model. And so we currently have a family council, and as you can see, our family council members are on the right-hand side. And so our family council members are caregivers of children who are enrolled in Medicaid or CHIP. And so they offer their expertise, their experiences, and their perspectives to really inform our care model. So as Richard shared, the first part of our braid talks about understanding need. And so we know that we can get an understanding from data and research and articles that have already been published, but we wanted to go straight to the source, and we wanted to connect with families and parents and caregivers of those families to really provide perspective there. And so a little bit of reflection on like what our family council has done within the past year, especially within our first year And so our family council has advised our Inc. communications in developing a postcard and figuring out how to really connect with families who qualify for Inc. And so our family council members have also participated in Inc. events to share their recommendations for how we can authentically and equitably engage families and form care teams. Next slide, Josie. And so within our second year of implementation, we realized we're missing a perspective. We could rely heavily on what parents can share with us, but we ultimately wanted to connect with our youth and our adolescents and young adults and figuring out like what are their experiences and how can we specifically create interventions and partner with community resources to make sure they have what they need. And so we developed our youth council to support the creation of a care model that is focused on uplifting and acknowledging the voices and experience of youth across the 5 counties that we support. And so our goal is to build knowledge, our own knowledge, and also the knowledge of the youth around public health and healthcare and community services and resources. And in doing so, we want to empower them to know what their options are and what they have access to, but also using their voices and their presence inside of their schools and communities to encourage their peers and teach their peers about what they have access to. And so here are a few quotes from youth council members who are part of our council. So again, our council members are in the 8th grade, between the 12th grade. And so here are the 5 schools that they represent from those counties. And so a few quotes. So we have Aslyn, who's in the 11th grade, and she shares that she wants to be something bigger than just being a kid. I want to be a helping hand in my community and help make impactful changes. I want to be a part of something bigger than just me. We have Layla in the 9th grade. I want to work on becoming a youth leader in my community and learn new things from other teenagers that have similar goals as myself. And then we have Nasir in the 10th grade. Being able to make change within the community as a high school student is an invaluable opportunity and experience. And so we hear that our young adults and adolescents want to do more and be more and learn more. And that's the goal of our youth council. And I will pass it over to Ashley.
Thanks, Alizia. Hi, everybody. I'm Ashley Wolard. I'm a licensed clinical social worker and integration consultant at NC Inc. And I'm also the lead integration consultant for our adolescent and young adult health work group, along with Dr. Chung. And I really wanted to be a part of this work group because prior to coming to Inc., within the 18 years that I've worked in the social work and mental health field, I've primarily worked with the adolescent population because it's my favorite age group to work with, because I think it is such a crucial time and phase in life, and it can be challenging even in the best of circumstances, but when you're adding difficult life situations on top of that, it's even more challenging. And I don't always think our society does the best job of preparing our young people to enter this adult world. And so I really wanted to work with adolescents to help give them the tools and skills and supports that they need to enter adulthood more successfully and better prepared. And so that's why I became a part of this work group. Next slide. So I wanted to share a little bit of information about what this population looks like within our Inc. members that we prioritize for care management. And so the 13 to 17-year-old age group makes up about 25% of our population, and the 18 to 20-year-olds make up about 20%. And so if you add those together, that's really about half of our Inc. population. And so this is a really large group that is important that we really need to focus on to make sure that we're providing quality care management. Next slide. And I also want to share a little bit about what our engagement has looked like for this age group, and what we're currently working on to try to improve it. And so this data here is for our launch year of 2022. And as you can see, out of all of the adolescent and young adults that we outreached, we were only able to engage about 19%. And we realized that's not that great. And we want to be able to improve that. But not just because we want to see those numbers go up, because that doesn't really tell us much about the quality of care that's being provided, or if these adolescents or young adults are actually seeing a benefit by engaging in care management. And so we really want to tailor how we're delivering care management to this age population so that it's something that they want to engage in and see value in. And so one of the first things that we're really focusing on and working on right now is to improve our adolescent participation in the care management process, because traditionally care management has really taken place between the care manager and their parent or caregiver. And so sometimes that care manager may never have even spoken to that adolescent, which obviously is a problem, because that doesn't give that adolescent much control over decisions being made. Nobody's asking what's important to them. Nobody's asking what their goals are. And it really prevents them from developing any healthcare autonomy. And so we really want to, we're doing research on best practices. We're working on developing guides and trainings and supports for our care managers so that they can incorporate that adolescent into the care management process and actually really make them the primary driver of the care management and their goals. And so sort of in conjunction with that, we want to be able to support our care managers with understanding confidentiality and healthcare privacy and how to navigate that so that adolescents can actually feel comfortable speaking with that care manager and have an understanding about, what information I share that is kept confidential and private, and what information they may have to share for safety reasons, or that they have permission from that care manager to share. And also so that the parent or caregiver feels comfortable with the care manager speaking with their teenager one-on-one. And so we really want them to have a clear understanding, a clear and shared understanding of what those confidentiality and privacy laws are, so that they can really collaborate together. And then another major initiative we're taking on is to expand our outreach technology, because currently care managers are primarily reaching members by a telephone call. And as many of you know, and this is not just for the younger population, this is for a lot of people, that we don't really talk on the phone as much anymore. And people are not always likely to pick up a phone call from a number that they don't recognize. Some don't listen to their voicemail, and a lot of people don't even have a voicemail set up, because especially for some of the younger populations, because it's just not something that they ever used. And so I think especially when we're trying to engage our 18 to 20-year-olds, this is something that's going to be really crucial, because not every entity that we work with uses texting. So we're doing a lot of research around laws and different technology that can be used, and really trying to give them all the tools, say, hey, this is going to be really beneficial. Let's try this. And so that a young person, an 18 to 20-year-old, may receive a text from a care manager saying, hey, this is who I am from this entity. This is what I can offer you. If this is something that you're interested, here's how to get in touch with me. Because otherwise they may have never even known that that person was trying to reach them. And then another major focus of ours is that we really want to be able to better address the needs of certain populations, like the LGBTQIA+ and unhoused youth. And so we really want to provide support and training and education to our care managers so that they can really tailor the care management approach for some of these populations. So for example, if a care manager is working with a transgender youth, that they have the knowledge and tools to ask about pronouns, that they understand some of the barriers and disparities that that young person may face in the healthcare system. And they know how to help navigate the system to identify providers that are gender affirming and get them connected to the gender affirming healthcare resources and providers. Next slide. Oh, and now I'll be passing it to Judy.
Hi, yes, good Tuesday, everyone. As Ashley was saying, and in the introduction, I'm Judy Lawrence. I am an integration consultant here with NC Inc. I am actually based in my home entity of our state division of juvenile justice and delinquency prevention, and that is a mouthful. So for the next few minutes, when I talk about that, I'll refer to it just as juvenile justice. I'm also the lead for our Inc. Juvenile Justice Work Group, and I'm part of the clinical leadership team at my home agency. I am really very excited to share with you just a little bit about how Inc. is working to make some really great changes for our youth that are involved with our very complex juvenile justice system here in North Carolina. So, I think it's just very important to note initially that through Integrated Care for Kids, Centers for Medicare and Medicaid did not require juvenile justice to be one of those core child service areas that these entities included. But in North Carolina, we have such a strong commitment to quality and continuity of care, especially for our most vulnerable youth across the state, that we recognized during that planning period that we wanted to include this population because we really did believe that including our juvenile justice involved youth, we could affect some really statewide, broad scale, systemic change that could improve the life, the health, and the well-being of these vulnerable youth, helping them also to navigate through this very complex juvenile justice system. But when we talk about juvenile justice in North Carolina, who and what does that really look like? Well, if you like numbers like I do, then I'm going to be speaking your language for a minute. If not, I'm just going to be very enthusiastic and let that speak for itself. How's that? So we have had some pretty major changes to our juvenile justice system over the past few years. First, back in 2021, we finally implemented Raise the Age, which meant that 16 and 17-year-old juveniles would no longer be tried in adult court. So we raised that age from 15 to include those 16 and 17-year-olds. Shortly after that, we implemented what we call Raise the Floor, because it used to be that children from age 6 could be tried in the criminal justice system through juvenile justice. We raised that age to 10. So we're really able to focus on those youth that are from that age range of 10 to 17. It's also very notable, though, to see that those ages 16 and 17 that were impacted by that Raise the Age, that they are the most represented of all of our youth who are coming before the court for delinquent behaviors. At any given point in time, in our 5 Inc. counties, there are at least 300 youth that are involved in our juvenile justice system. Now, here in North Carolina, we have 100 counties total. So you think about that, that's a pretty significant number. And sometimes it can be double that, just depending on where the cases are within that system. But at any point in time, there is typically at least 300 youth just in those 5 counties. Not all of them are receiving Medicaid, but the vast majority of them are. And that means that they can be receiving care management through our INC model. So why am I telling you all of this? Just kind of to get down to the nitty-gritty of when we talk about vulnerable youth, I want to talk about our youth development centers. This is the most restrictive commitment that our youth can be confined to or court ordered to, and it's typically the longest term. So in 2021, all of the youth that were in all of our youth development centers across our state, we took a look at that and found that 100% of them had at least one mental health diagnosis. 100%, every single youth that was going through this system and was in a residential placement at a YDC, a youth development center, and 80% had more than one behavioral health diagnosis. Oftentimes that went hand in hand with substance use. And so when we looked at just that overall trend, we found that of all the youth in the YDCs in 2021, they averaged 3 distinct mental health or substance use disorder diagnosis, and some had up to 9. That's huge. These youth need support. They deserve that. That is our role. That is our responsibility to serve them. And so let's move on to the next slide so that I can actually share a little bit, just one concrete example about how INC has been able to advocate for this change for these youth. Because again, we have that commitment to ensuring quality and continuity of care. So we did a lot of research. That's kind of where you have to start, right? We did a lot of research. We had a lot of conversations with our state Medicaid and juvenile justice divisions. We found a gap in our Medicaid services that was having a really negative impact on our youth who were being ready to be discharged from those youth development centers. So we decided through our work group, our internal INC juvenile justice work group, that we wanted to make that our top focus in 2022 and carry it over as long as we needed to, because this was so important. So let me just kind of tell you a little bit about how that works here in North Carolina. When a juvenile offender is committed to a youth development center, their Medicaid goes into what we call suspended status. And basically that means that they do not have Medicaid coverage because all of their physical, mental, and behavioral health needs are to be taken care of and funded through our Juvenile Justice and Delinquency Prevention Division. So they really don't have that need for Medicaid during that commitment time. But to get that unsuspended when they are ready to be discharged, our state requires their legal guardian, which may be themselves if they have turned 18 and are being discharged, but oftentimes it's a parent or legal guardian, that they have to actually call or visit the local Department of Social Services that administers their Medicaid and request it to be reinstated. And to complicate it even more, a federal requirement is that it cannot be reinstated more than 24 hours prior to that youth being discharged and released back into the community. This is a huge barrier, and it's a hardship because that parent or that guardian or that youth themselves, they have a lot going on and a lot on their plate just preparing to re-enter the community outside of that commitment and that confinement. And the youth really needs that coverage ahead of time because they have physical needs that need to be met. And like we just talked about, mental and behavioral health needs. They need to already have comprehensive clinical assessments done. They need to know exactly what type of specialist they need to be seeing, and they need to have those appointments set up because there can be a really long wait period. So how is INC advocating for this change? I'm sure you're wondering that. So glad you asked. Well, we did find out that North Carolina Department of Health and Human Services has a statewide integrated case management system that includes all of those Medicaid programs, and it works across all 100 counties. So because of this, we at Inc. said, well, we already have the tool that we need to automatically reinstate or unsuspend that Medicaid coverage for these youth. So why is the state, not the feds, but why is the state requiring that personal contact to happen if we could actually reinstate that? Well, the first thing that we found is some challenges with communication between the state departments of Medicaid and juvenile justice. Medicaid, honestly, did not realize the negative impact that this policy was having on our youth. On the flip side, juvenile justice didn't even know that this was a state policy and regulation and that automation could be possible. They were even in discussions with leadership at the state between those two organizations about another manual process. But instead of having the guardian do it, pulling it to the state. But at Inc., we said, well, why do we want anything manual if we have the capability to automate it? So once we got everyone on the same page, everybody was like, well, this is a no-brainer. We should do this. And I guess you're probably thinking like I did that, hey, 5 minutes, flip that switch, and let's get it done, right? Well, it's a little more complex than that, not quite that simple. It's something that we are still working on. But I'm going to tell you, why didn't it take 5 minutes when it is something this important for these youth to get the services that they need? We've wanted this for decades. There have been people advocating for this for decades. And in a matter of about 12 months with Inc., we are closer than we have ever been, because this sounds like such a little thing, but it could have such a big impact. We're just caught up in that web of red tape right now. And so I am now going to just turn it back over to Richard to kind of do any wrap up that you might want. Thank you.
Great, thank you. Thank you, Judy. Thank you, Ashley. Thank you, Elysia, for sharing a bit about Inc. and our work in engaging young people and families, the care management efforts around adolescents and young adults, and then Judy sharing about this specific sort of policy wrinkle. I think the example Judy shared is a really good one, because in the model of Inc., which includes a range of different core service areas, as we call them, in each of these domains, inclusive of the justice system, we're finding a lot of these weird realities, basically, right, that have these cascading impacts on young people. As Judy mentioned, it seems on paper like such a small detail, and yet it has such profound consequences. And it's not until somebody is able to identify that, to explain the implications of the thing, and then to argue for a change, that actual change happens. And I think for all of you who are engaged in making policy, I think there are many examples where it doesn't seem like such a big deal, and yet it has such profound consequences. And so it's a really good example of Inc. trying to do right by young people who quantitatively are relatively few, but are in a particular situation where they have special needs that we need to address and care for. And so with that said, we'll pause. I'm hoping the youth panelists will have questions for us, and we'll welcome some engagement from the audience as well. So thank you again for the opportunity.
I just want to say thank you all once again for explaining to us what Inc. in North Carolina does. And we do have a few questions that we would like to address today in no particular order. My fellow counterparts, please.
Hi, my name is Julie. My question is, are there a limitation on the number of youth or which youth can serve, can be served in the 5 counties, or is everyone eligible to be part of this program?
Yeah, it's a great question. So there's about 95,000 children and youth, again, from birth through age 20, roughly speaking. And the way that CMS, which is the federal agency administering this, sort of dictated it is that it is, again, Medicaid and CHIP insured young people who live in the specific counties that we're working with. And so there is kind of a limitation in that regard. There's about 15,000 out of that 95,000 who have been identified through our data processes as really potentially benefiting from additional care management support. So we have these kind of different levels of support that we try to offer, which is sort of in view of the limitations of the model itself, right? That we can't do everything for everyone. And so there is some obligation to really try to make best use of the resources we've been given. And so there's some sort of thought behind that. So there's about 15,000 who've been elevated into the care management model because of particular needs and opportunities that we see. All young people, though, from 0 to 20 in the counties also benefit from broader efforts that we are engaged with schools as well as primary care practices around general quality of care, access to care, and other initiatives. And so, so at some level, everybody's involved, but then there's like a subset that are particularly engaged in the care management piece. But thank you for the question.
Thanks so much for that. I also had a follow-up question on those counties. What was it in specific that made you choose those 500? It sounds like you've got a lot. Just curious what made those 5 stand out to start with.
Yeah, another great question. So the 5 counties, there are a few practical considerations. So Duke University is kind of the primary grantee, so to speak, and then the University of North Carolina, Chapel Hill, which is about 15 miles down the road from Duke, is the other. And so there was some consideration of that just because both institutions have existing partnerships with both clinical and non-clinical entities within those counties. There was also some consideration about how do we set up the model so that it can be evaluated in a meaningful fashion. And so those counties were chosen partly because of the sheer number of young people in those counties, as well as the diversity of sort of sociodemographic characteristics, as well as lived experiences among young people in those counties. For example, in North Carolina in particular, and similar states, there's real need to think about urban versus more sort of rural communities, given the types of factors that each community might experience. And so these 5 counties gave us a really good sort of slice of that diversity.
So you guys talked about like collecting data to create your policy, but I was wondering if you guys are collecting any outcome data to show if there's any improvement in youth in your counties.
So I think just to make sure I heard you correctly, so sort of outcome data to demonstrate improvement among youth, is that right?
And how is it being collected and analyzed?
Okay, yeah, so it's a great question. So as you know, as I mentioned, for sure, I think having a robust evaluation is critical to demonstrate the impact of everything that we do. And so there's a few ways in which that's happening. So given that the model is highly based in this care management mechanism, there are what we would call process measures related to care management, some of which Ashley shared, which are sort of basic nuts and bolts about outreach, engagement, and then ongoing collaboration with young people, just having data around what those processes are and how they're trending over time. There's also what we would call more sort of healthcare quality measures that we're looking at. This is a part of what I mentioned in terms of this alternative payment model, which is a way for clinical sort of clinics and hospitals and health systems to partner actively with the model around specific types of data. For example, we have specific measures around let's say social drivers, as I talked about, so food insecurity and housing instability. There are certain traditional healthcare models around emergency room utilization, for example, or follow-up after a mental health hospitalization. So there are an array of kind of data in that domain that we're capturing as well. Biggest picture and probably most important to CMS, which is again the federal funder, is around sort of high-level hospitalization, out-of-home placement. Some of these, what we would call more downstream impacts or outcomes that young people might experience, and what can we as a model do to prevent them altogether. And so some of those out-of-home placement pieces, and then the federal government, for a lot of really good reason, is very interested in the cost of care, just because one of the challenges, of course, of our healthcare system generally is the inability to make it sustainable from a cost standpoint. So there is some obligation on our part to improve quality and outcome, but also to do so as efficiently as possible so that we can do the same thing for more kids over time. So I hope that answered your question. Thank you for it.
Thank you for your answer. And a follow-up question is, are you guys conducting like any focus groups to collect any qualitative data to see how experiences improved?
I might ask Elysia to comment a little bit about that. Elysia has been really wonderful in driving a lot of our engagement, and the qualitative piece to your question is really fundamental, right? It's very easy for somebody like us to think just about the numbers, but the numbers don't tell the whole story, certainly. And so, Elysia?
Yeah, so as far as quality data, being that we just wrapped up our first year, we are in the planning process of figuring out what are the best ways for us to move forward in hosting focus groups that connect with families and young adults and adolescents to figure out what's working and what isn't, and what ways we can tweak components of our model to like fill those areas and those gaps. And so we are actually starting focus groups with members of our family council next month and figuring out like how is their presence on our family council beneficial, and how can we maximize on them participating in our council and figuring out what ways we can improve there. And then also we are fortunate to have family council members who have INC eligible children as well and have been outreached by family navigators and integration consultants. And so using their perspectives as well to collect data on what's working with our communication so that we can tweak that for broader engagement as well.
I had a question about more so the data assessment and evaluation process. It sounds like data is such an important part of this model, and I was curious to know if youth are really involved in evaluating this data and helping to draw conclusions. For example, we talked about like the automatic reinstatement, but was that kind of like a youth identified challenge, and are youth really just involved in that data evaluation process?
It's a great question. So I might ask Elysia again, in terms of the Youth Council, sort of how we've framed up bringing information to the Youth Council for their sort of perspective on that. And I love the premise of the question, this idea that there are data, but that, you know, our eyes as, you know, staff on the model can only see so far. But I think other eyes with lived experience kind of looking at the same data can have a different perspective. And so, Elysia, are there thoughts on that?
Yeah, so with our with our youth council and our monthly meetings, we do talk about a specific core child service area or system that relates to the INC care model. And so when we're talking about that specific system or core child service area, I rely heavily on the data that our integration consultants supply at weekly check-in meetings that take place and presenting like engagement numbers around that specific system, and figuring out like in what ways do our youth council members engage with this system on a day-to-day, and while also helping them acknowledge the ways that they interact with these systems, also getting their perspective on like what are ways that we can increase engagement or connect with young adults and adolescents based on the data that we kind of share as a team, starting with our integration consultants. So yes, to your question, that our youth are involved, just as an overview of like, this is the data, this is what we're seeing, and we really rely on their perspective to figure out how to improve those numbers.
I also wanted to add something about the Medicaid reinstatement for juvenile justice involved youth. And yeah, a lot of that has come from our lived experience working with youth and families in those systems, because, you know, Judy is a part of juvenile justice, but I've worked within the juvenile justice system for a long time, and I was doing mental health assessments for kids that are involved in juvenile justice to try to connect them to treatment services to mitigate those factors that are contributing to their involvement in juvenile justice. And so, you know, when I was doing these assessments and working with these kids and families that are coming out of youth development centers, it was such a challenge to get them connected to any services because their Medicaid has been suspended and it can't be reinstated until after, you know, they're coming out. And then there's this big gap in supports when they're returning to the community. And so, you know, I've heard from so many kids and families about what a problem that is. And so, you know, it's something that we were really passionate about trying to change. Just wanted to add that.
I'm curious to know what tangible impacts, based on the feedback that you've gotten from the youth, what tangible impacts have, I would say, that you have made or the kids have made, and what adaptations or implementations have you made in the feedback you've given from the youth?
In terms of adaptations, do you mean in terms of the care management supports or other aspects of the model?
Just in general, I'm just trying to get a gist of what impact does youth have when it comes to INCU, and what any adaptations have you made from their feedback?
Yeah, it's a great question. And I think sort of getting to that qualitative piece, right? The actual perspectives of individuals, I think is where there's tremendous value. We certainly want to be data-driven, but then complementing that with actual perspectives. And I think we, to be honest, are really on the front end or the early end of that process. Last year was the first year of our model implementation, and for any of you all who have implemented a model like this, you know, there's a lot of sort of busy work that goes into simply getting something stood up. And I think we're just kind of getting our legs under us at some level. And trying to really ensure that these other mechanisms to actively learn along the way are in place. And so I do think we've learned from individual young people and families at sort of that individual level, you know, key insights where we've tried to tweak things in specific ways. But as far as broader changes to the model, I don't know that we've gotten to that point yet. Now, I certainly welcome any of our other team members who have a specific example that might be relevant, because it really is a great question. Ashley?
Yeah, I wanted to add something about that too, because I agree with Richard, because the model is still so new. But again, I think like when I talked about some of the initiatives that the adolescent and young adult work group are working on, a lot of that, again, comes from our past experiences working with youth and families in the care management and case management world. And I've heard from especially the adolescent population countless times about how everything's happening around them, and it's like they're not even there, and nobody's asking what's important to them. No one's including them. And so that's why one thing that I'm really passionate about implementing with INC is that they are that they're a part of the care management process, that they're the drivers of their healthcare goals, and that it's not just something that's happening around them. So that's one thing that INC is really trying to make happen.
I would like to add something also to that from my experience. I do, you know, we really do listen to the feedback that we get from our youth and families. And one of the adjustments that we have made here in year 2 is Richard had talked about the, you know, the data and how it, you know, tells us which youth that we should engage, like prioritize for engagement. But we heard a lot from the guardians and the parents over that first year, and even feedback from some of those young adults that maybe they had siblings or someone else that didn't meet that criteria of a high priority. So now we're able to have some referrals made outside of just what the data is doing. And we are opening that up starting hopefully by May, where we're scheduling training right now, but for our juvenile court counselors within juvenile justice to make these referrals. So we're hoping that that will increase that. Not just that, as Ashley said, talking about, you know, the work they do, not just increasing the number of youth engaged because we want the number to go up, but because we really want to provide them all of the tools and all of the support that they need for success. And when you think about those young adults or those adolescent youth that are getting ready to become adults, it's really essential that we prepare them for that next stage in their life, because it's not like something huge happens, on day 365 of your 17th year, and then boom, all of a sudden, day 1 of 18, and you're an adult. You have to be prepared for that. So we do listen to the feedback that we get, and we are working on those changes. And I know our youth council and our family council, Alicia works so closely with them and brings that back to us so that we can really start planning ahead and keep testing these different processes throughout this model.
Thank you. Do we have any comments, questions from?
I have one last question.
Okay.
I love your passion and your love and your appreciation for the feedback from the young people. I know you said that you're still in the first year of review, and what systems of accountability you currently have in place so that feedback that you receive year after year is getting implemented, and the young people that are giving you their feedback are seeing it being implemented year through year, so that not 3 years down the road and we're still looking at year 1 data? Or do you have kind of like a plan to ensure for like the accountability and implementation?
Yeah, it's a great question. And I think what you're getting at is, it's one thing to kind of hear something, it's another to be accountable, it's taking action to the thing. And I think that is a really important and astute question for sure. There are a few sort of groups within the model that we didn't allude to that are tasked with that kind of oversight. So there is a partnership council, which includes family members and other community-based leaders who have sort of a leadership authority over the model. And that includes kind of taking a look at information and data that's brought forth and evaluating progress over time. There is certainly the family and youth councils as well, who have a similar role in holding us accountable to the values that we've professed, as well as the promises that we've made. And then certainly there's CMS, which is the funder, who ultimately they pay the bills and keep the lights on. And so, there's certainly a mechanism of accountability there. But I definitely appreciate the question. I think it's exactly the point of being accountable to our best aspirations, especially as we're sort of getting out of the gates and trying to move things forward. So hopefully, if we get invited back for next year's conference, we can report back on the progress that we've made.
And I wanted to add one more thing to that too, because I think, as we're listening to this feedback and implementing some of these changes, there's a lot of ways that we look at that data, and we hope to see an increase in engagement for a longer period of time, and that we're seeing goals that they're working on being achieved, because we do track that. And there's a part of the model where they're divided into different service integration levels, 1 through 3, with 3 being the higher need kids, and 1 being the lower needs. And so, we take in all this data that includes like healthcare and so many social determinants of health from all these different systems. And ideally, as we, if we have a family and a young person that's really engaged in the model for this period of time, that we would expect to see that service integration level drop. So if they were a 3, that maybe the next year they're going down to a 2, so that we're seeing that there's actually progress. And so there's lots of different ways that we're trying to track and measure that.
Thank you so much for just answering. We appreciate you, and we appreciate the work that you all are doing to make sure young people and adolescents are successful products of society. At this time, we are now in our lunch in close, and we thank